Hello, I'm Jamie Stoller. I'm a pulmonary critical care physician at the Cleveland Clinic, and I serve as the chairman of our Education Institute. I'm delighted to talk to you today about an important and underappreciated topic, that of Alpha-1 Antitrypsin Deficiency. In talking about this in three parts, I will first organize my comments in part one by talking about the history of Alpha-1, the epidemiology of Alpha-1 Antitrypsin Deficiency, and the physiology of Alpha-1 Antitrypsin Deficiency. In part two, we'll talk about clinical features of individuals with Alpha-1 Antitrypsin Deficiency, or AAT deficiency, and also the natural history. And then finally, in part three, we'll talk about diagnosis, how to recognize the condition, how to make the diagnosis, and then finally, the specific therapy, the evidence regarding specific therapy for Alpha-1 Antitrypsin Deficiency, namely augmentation therapy, which is the infusion of pooled human plasma, Alpha-1 antitrypsin, into the veins of individuals who have severe deficiency. With that said, in part one, I will be invoking information that comes from various sources, including the National Heart, Lung, and Blood Institute Registry for individuals with Alpha-1, a study in which we at the Cleveland Clinic had the privilege of serving as the coordinating center and participated. This was a multi-center, 7-year study involving 37 centers throughout the United States and Canada that followed these patients in order to characterize, as shown here, the clinical and laboratory course of individuals with severe deficiency of Alpha-1 antitrypsin. This was not a randomized trial, but rather an observational cohort study, and therefore provided important natural history data when we talk about the implications and analyses with regard to augmentation therapy. We need to be mindful of the shortcomings of observational studies rather than randomized trials. I will also invoke some of the findings from this document, the American Thoracic Society, European Respiratory Society guideline document, published now in 2003, with current work to provide a revision of this document. This, however, is the most recent ATS-ERS document that provided an evidence-based systematic review of the literature regarding the management with recommendations as I will discuss. Now, with regard to history, Alpha-1 antitrypsin deficiency demonstrates Pasteur's quote that chance favors the prepared mind. And in fact, in telling the story of the description of Alpha-1 antitrypsin deficiency, which I'll point out dates, as you can see, to 1963, when it was described by two scientists, Carl Bertil Lorell, a senior protein chemist working in the laboratory in Malmö, Sweden, and Sten Eriksson, whose image I'll show you on the next slide. Sten is a close colleague. They were working together. Eriksson, a senior chemist, was doing a quality control study in the laboratory at Malmö, a very distinguished protein chemistry laboratory where Waldenstrom's macroglobulin anemia, for example, was described years before. And he observed that in 1,500 serum protein electrophoresis patterns, 5 of those specimens lacked protein in the alpha-1 region of the SPEP. He then turned to Sten Eriksson, again, chance favors the prepared mind, who was then a medical resident, and asked Sten to investigate these 5 specimens. It turned out that Sten was following several of these patients in his longitudinal clinic and noticed that several of them had emphysema at an early onset and seemed to have a family history of emphysema. So again, in this chance collaboration between a senior scientist and a medical resident came the observation and first description, now 51 years ago, in 1963, of Alpha-1 antitrypsin deficiency, characterized by a deficiency of a protein in the alpha-1 region, known then to be alpha-1 antitrypsin, accompanied by clinical manifestations of emphysema, usually of early onset in this early series, and that was familial. This is Sten Eriksson on the left, and you can see he's delighted to be in the picture. In fairness, he had just gotten off a plane from Malmö at a meeting we both attended, but this is one of the pioneers of Alpha-1 antitrypsin deficiency. Since 1963, as shown here, there's been an explosion of information about Alpha-1 in the sense that you can see that in aggregate, using the mesh search term of Alpha-1 antitrypsin deficiency, there are almost 3,000 citations. and all of the information that we'll be discussing in terms of its clinical history, its therapy, its pathophysiology have been generated through very careful work by a number of very talented investigators and clinicians around the world in the 51 years since the original description of this disease. Now, in terms of epidemiology, I'd like to suggest that this is more common than any of us knows, and I'd have you consider as you listen the number of patients that perhaps you've seen in your practice with alpha-1 antitrypsin deficiency. For those of you who are suggesting that you've not seen any, I'd like to suggest that we've all seen such patients, and perhaps they've escaped our attention, and I'll try to defend that statement in my comments. How common is this? We have two lines of reasoning that inform our understanding of the prevalence of alpha-1. The first is an indirect line of reasoning as follows. We know that of the roughly 24 million Americans with COPD, that is to say emphysema, chronic bronchitis, perhaps even bronchiectasis, that about 3 million or so are estimated to have emphysema. We know that from the work of Jack Lieberman and colleagues at the Sepulveda VA, where they sampled 965 consecutive blood specimens from veterans attending the COPD clinic there, that about 3% of these individuals had a severe variant of alpha-1 antitrypsin deficiency called PIZZ type. Let's park and hold that nomenclature for a moment, but for the moment regard PIZZ as the most common severe deficient version of alpha-1, the most common allelic deficient combination. So that 3% of perhaps 3 million leaves us with an estimated US prevalence of lung-affected individuals of about 93,000 individuals in the United States. And we know, as I'll suggest, that not everyone with this genetic predisposition in fact develops emphysema. So this estimate is likely an underestimate of the total prevalence of individuals with alpha-1. Now, more direct population-based screening studies also provide epidemiologic estimates of the frequency of alpha-1 antitrypsin deficiency. And there are two landmark large studies. The first done by O'Brien and colleagues in 1978 in Oregon, in which they tested by heel stick bloods 107,000 consecutive newborns in the state of Oregon, testing their blood for alpha-1 antitrypsin levels and allele combinations. And they could identify, as you can see on the right-hand side in the blue highlighted area, they estimated the frequency of severe deficient individuals as 1 in 5,000 newborns. A little bit later, in a larger study conducted in Sweden by Thomas Fager and colleagues, they sampled 200,000 Swedish newborns in the same way and estimated the prevalence of about 1 in 1,500. So the prevalence in Scandinavia of the most severe deficient type, namely PIZZ type, is about 3-fold higher in Scandinavia, where the Z gene was felt to have emerged initially, than it is in the United States. However, if one takes a blended estimate from these two numbers, about 1 in 3,500, and extrapolated to a United States population of about 315 million, that leaves us with a concordant estimate of about 100,000 severely deficient individuals with alpha-1 antitrypsin deficiency. Now, for those of you who responded to my question, I've not seen such a patient, the question might be asked, where are all these individuals? And some interesting insights emerged from a study that was done by Ed Silverman and colleagues then in St. Louis. And they went to the St. Louis Blood Bank and sampled 20,000 blood specimens that were donated. They reasoned that having alpha-1 antitrypsin deficiency neither favored nor biased against blood donation, which is a reasonable assumption. Of those 20,000 specimens, you can see that 7 were found to be the severely deficient PIZ type of alpha-1 antitrypsin, lending a prevalence estimate of about 1 in 3,000, which agrees again with the data from the two newborn screening studies that I shared with you on the last slide. This rate among the blood bank donors suggests that there would be 700 individuals in a population of 2 million, which was the population of St. Louis at that time. They then got on the phone. I'm sure St. Louis, like Cleveland, being a relatively small pulmonary critical care, gastroenterology, and allergy community, and they called the physicians with those practices, asking them, how many patients in your practice do you follow with alpha-1 antitrypsin deficiency? And as you can see, they reported only following 28, leading to the impression that only 4% of the total expected number of individuals in St. Louis were clinically recognized by the physicians that they surveyed. And so this led to the conclusion, supported by other pieces of data that I'll share with you, again, the major message that this being highly under-recognized and therefore important to recognize, because recognition of this condition has both genetic implications for the family as well as potentially therapeutic implications for the patient in front of you in your office. So the concept has emerged of this iceberg, if you will. The tip of the iceberg is that minority of individuals, perhaps it's 4%, perhaps it's 8%, but it's clearly a small minority of individuals with alpha-1 antitrypsin that have been clinically recognized. And the larger base of the iceberg consists of two populations of unknown proportions. One proportion are those individuals who have alpha-1 antitrypsin deficiency of a severe type, but who are clinically unrecognized because they have no signs or symptoms whatsoever. And the other population, and it clearly exists, are patients who we see in our offices who are highly symptomatic, who we may carry with a diagnosis of asthma or COPD or chronic liver disease, but who in fact have this genetic predisposition, alpha-1 antitrypsin deficiency, as the contributing cause of those underlying conditions. Now, lest we think that this problem of under-recognition is unique to the United States, this is in fact an international problem, as you can see in this review of the literature that was published by Maurizio Luzetti and Neil Searsholm several years ago. You can see that in the second to the left column, the expected cases, the number of diagnosed columns in the diagnosed cases in the column next to the right, and the percent of expected cases on the right. You can see that in aggregate, it's a small minority, less than 1% of all expected cases that have been diagnosed in aggregate, and the highest percent of patients recognized is in Sweden, in fact, where the condition was recognized initially in 1963, and even there it's well less than 3%. So under-recognition is regrettably an important challenge. Now, other lines of evidence that support under-recognition have been developed. We conducted, for example, in 1995, a survey of 300 individuals who were self-reportedly severely deficient with a ZZ phenotype. We asked them, how old are you? You can see their mean age was 48 years. Had you smoked? 81% had. Are you short of breath? 90.2% reported having dyspnea. We asked them, at what age did your dyspnea begin? And you can see the mean age was 35 years of age. We then asked them how many years transpired between the first diagnosis of alpha-1 and the first time the diagnosis was made or was rendered. And you can see that although there's a large range, an index of dispersion, that the mean diagnostic delay interval, the time between first symptom and first recognition, was 7.2 years. When we asked them how many physicians did you see before the diagnosis was first made, you'll see a quarter on this slide reported having a diagnosis made by the first physician they saw or consulted for their symptoms. But you'll see that 43.7% reported seeing between 3 and 10 physicians, and 12.5% reported seeing between 6 and 10 physicians. Again, this concept of patients who have fixed airflow obstruction or symptomatic but who go unrecognized is, I'm sure, recognized to all of you who've made the diagnosis, is certainly common in my practice, in which I've seen patients like this not infrequently. Now, I would love to report to you that our diagnostic delay interval is decreasing with time. That is to say, we're getting better as a medical community at recognizing this condition. But unfortunately, these data, taken from a 2005 study that we conducted, failed to support that impression. Specifically, on the vertical axis, you see the mean number of years between first symptom and first recognition, the diagnostic delay interval about which we've been talking. And on the horizontal axis, we stratified these groups into those diagnosed on the left with alpha-1 before the year 1980, and on the extreme right, diagnosed with alpha-1 since the year 2000. And so you can tell that if we were getting better at recognizing this earlier, the diagnostic delay interval for more recently diagnosed individuals should be shorter than those who were diagnosed years ago, in which case this curve would be moving from left to right down. But you can easily appreciate this curve is not moving down. It's in fact quite horizontal, if not worrisomely even increasing. And again, other independent data to reaffirm this idea of persisting under-recognition comes from other studies. Mike Campos and Sandy Sandhouse published also in 2005 a study of diagnostic delay. You can see in the rightmost column, they estimated at that time the diagnostic delay interval to be 8.3 years, and more recent studies from Germany and Italy by Kohnlein and Grulich, respectively, suggest that even as recently as 2013, when this was last examined, the diagnostic delay interval on average is 6 to 7 years, which again reminds us that these patients are in our midst, but we're not recognizing them. Now, what are the reasons for under-recognition of alpha-1? There are several potential reasons. The first is, of course, inadequate knowledge about the condition, and I'll share with you some data to support this fact. The second is inattention to the guidelines that exist, and we believe that to be also contributing. And the third is the concept of therapeutic nihilism, that because physicians do not believe we have an effective intervention, why would we make the diagnosis and burden the patient psychologically and clinically with a genetic diagnosis when there's no therapy? Of course, I'd like to submit that we do have effective interventions, albeit incomplete, yet at the same time, as we'll discuss in the third component of this series, therapy is rapidly evolving, so that even though we don't have the definitive therapy perhaps today, it's likely that that will happen in the near term. And so in my view, there's an imperative to render a diagnosis not only for the patient's well-being in terms of conventional management strategies, the possibility of augmentation therapy, but also because family members are at risk, and watching these family members carefully with regard to the development of lung and liver disease is important. Now, evidence that this is poorly understood, some comes from my own institution, the Cleveland Clinic. Rachel Taliercio and I, one of my colleagues in pulmonary, conducted a study several years ago in which we surveyed internal medicine residents and respiratory therapists about their knowledge of alpha-1 antitrypsin deficiency. You can see the response rate was moderate. When we administered a simple examination of 30 questions about alpha-1, the percent correct responses from both the internal medicine trainees and the respiratory therapists were both low. No statistically significant difference between them of 54 and 52% respectively. When we looked at a subset of questions, particularly regarding the diagnostic recognition of alpha-1, you can see that the results were slightly better, 63% versus 61%, but I think we could agree that certainly bears some improvement. And we could find no effect among the internal medicine residents that increasing seniority, that is to say senior residents, responded with better scores than did the interns. Now, another piece of more recent data, again supporting inadequate knowledge, comes from a paper conducted by Grulich and colleagues in Germany and Italy, in which they surveyed internists, pulmonologists, and general practitioners. They asked these participants, how much do you know about lung disease caused by alpha-1 antitrypsin deficiency? And you can see, as I've boxed among the pulmonologists, on the left from Germany, on the right from Italy, you could see that the number of individuals responding either none at all or a little was alarmingly high, 44% among the pulmonologists, 25% among the Italian pulmonologists. When they then asked the same question to the internists, the numbers were regrettably even higher, 36% among the German internists and 50% among the Italian internists. And then finally among general practitioners, yet higher again, 43 and 64% respectively among the German and Italian respondents. So you can see in aggregate the literature certainly suggests an inadequate knowledge base, which certainly is contributing to under-recognition and represents an opportunity in conversations like this with colleagues to enhance diagnostic suspicion. There is a glimmer of good news. An interesting editorial written by my friend and colleague Mike Campos reported trends in diagnostic testing, and as you can see in the box on the left, in the red box, year over year, in accounting for all of the tests done by various sources for alpha-1, the numbers seem to be growing, doubling in fact between 2007 and 2010. Furthermore, over this period of time, some 4,314 individuals were recognized with alpha-1, and the diagnostic yields of such testing have gone from about 1.1 to 4.3%. So testing certainly can identify such individuals, and there are favorable trends. Another piece of important news is that not only might the diagnosis be made by those of us who are physicians, whether we are pulmonologists, family practitioners, general internists, but allied health providers, nurses and respiratory therapists can also participate. A piece of data from a study that we published with colleagues was a multi-center study in which therapists at the pulmonary function lab were offering patients testing for alpha-1 when those patients during spirometry showed fixed airflow obstruction. And you can see that in those patients willing to be tested, some 3,152 were in fact tested, of whom 0.63 or 20 of these patients were found to be newly severely deficient with the PIZZ type. Finally, a more recent publication by our group in collaboration with colleagues at the Medical University of South Carolina, Charlie Strange, and with the American Association for Respiratory Care, Tom Kallstrom and colleagues, looked at the impact of an online training program for respiratory therapists. This was a 3-hour module with instruction about the elements and basics of alpha-1 antitrypsin deficiency in order to enhance therapists' awareness and knowledge. When we looked at the number of therapists who took that program, some 378, and when we looked at the number of specimens submitted for free, confidential, at-home testing in the so-called ACT trial, there were some 111 patients who were referred to the ACT trial who had specimens recommended by the therapist who had taken the course. And of the 62 specimens that were received at the time this paper was analyzed, you could see that about 3.2% of those individuals were again found to be PIZZ deficient, and another individual to have the other heterozygous state PISZ with a serum level just above the so-called protective threshold value of severe deficiency, about which we'll speak a little later. So you can see in the boxed red are the results of this trial. Again, this is proof of principle that in fact our colleagues in respiratory therapy can help us render the diagnosis of alpha-1 if empowered to recommend testing. Now, in closing the first part of this 3-part series, I'd like to just address the physiology of alpha-1 antitrypsin and the deficiency state. This is a glycoprotein that's produced, like most proteins, primarily in the liver. The protein is made in the hepatocyte, secreted into the bloodstream, perfused the various organs, including the lung, and provides protection at the level of the lung parenchyma against neutrophil elastase being a threat to the integrity of elastin, which lives, of course, in the lung interstitium and provides some of the structural integrity of the lung that the lung depends on. Now, like a glycoprotein, this is translocated in the rough endoplasmic reticulum, or RER, glycosylated, transferred to the Golgi apparatus, and ultimately secreted into the bloodstream, where again it circulates and at the lung level provides protection against neutrophil elastase, a proteolytic enzyme that derives from the primary granules of our polymorphonuclear leukocytes. Normal blood levels, which is one of the useful tests for making the diagnosis of deficiency, normal blood levels vary, of course, from lab to lab, but using a turbidimetric method called nephelometry, the normal blood levels in our lab, quite similar to most, is 100 to 220 milligrams per deciliter. Using micromolar terminology, this number is 20 to 53 micromolar. We'll come back to that concept when we talk about the protective threshold value. A word about the structure of the molecule. This is a 394 amino acid glycoprotein. When I describe this to my patients, perhaps this metaphor will be useful to you, I liken it to a string of pearls, 394 pearls long, with each pearl corresponding to a single amino acid. And in order for the protein to be normal, the so-called M type, M for middle, each of those 394 amino acids or 394 pearls needs to be the correct pearl in the correct position. There are 3 carbohydrate or sugar side chains that are responsible for both the folding as well as the clearance of the protein. The normal human glycosylated protein has a serum half-life of 3 to 5 days. The recombinant prokaryote-produced protein, which lacks carbohydrate side chain, has a serum half-life of 3 to 5 minutes, so is an unappealing pharmacokinetic and pharmacodynamic substitute for pooled human plasma protein as a treatment option. We'll discuss in part 3. This is the molecule. You'll notice on the top of this ribbon diagram that green strand, which is the active site of the protein. It's at that position, as I'll show you in the upcoming video in 2 slides. It's at that position that neutrophil elastase binds alpha-1 antitrypsin, binds it, cleaves that site, cleaves the active site, that green loop, and then releases steric energy in the molecule like a mousetrap that catapults the neutrophil elastase to the backside of the molecule, being bound quite tightly and being inactivated by binding alpha-1 antitrypsin. This again is a cartoon which shows on the left alpha-1 antitrypsin and on the right that fish-like looking molecule neutrophil elastase. You can see that the neutrophil elastase binds the green active site, which is a methionine and serine residue at positions 358 and 359 respectively, binds, cleaves the molecule, and looks rather like this mousetrap mechanism taken from the elegant review by David Lomas and colleagues in the New England Journal several years ago. On the top panel, that cauliflower-looking molecule is neutrophil elastase. The yellow active site is on the prior diagram, the green active site that I showed you. It is bound, as you can see in the bottom diagram, that portion of the molecule is cleaved by neutrophil elastase, and then in that sweeping motion, the molecule is catapulted to the backside. And let's consider this in a video that was kindly provided to me by Dr. David Lomas, whose work this is. Here in this video, one sees the blue molecule neutrophil elastase coming down, taking the bait or binding the active site, cleaving it, and then being catapulted to the backside of the molecule. The main molecule here is alpha-1. The blue molecule is neutrophil elastase. I think we could all agree this is a rather elegant molecular ballet. And in order for this ballet to be as precise as it is, of course, the primary structure of the alpha-1 molecule needs to be preserved, needs to be normal. When there are variations in the molecule structure at particular strategic positions, this may compromise the ability of the molecule to both bind neutrophil elastase as well, as we'll discuss, to be secreted from the liver cell in normal amounts. And so here we start to talk about the various alleles or genetic variants of the normal molecule, the normal type being so-called M. There are more than 120 allelic variants described to date. The most common severe deficient type of which, as I mentioned before, is the Z type. And in the Z-type allele variant, there is a single amino acid substitution at position 342 of the molecule in which a lysine residue replaces a glutamic acid. And that single substitution of the molecule destabilizes the molecule, as I'll show you on the next slide, and allows adjacent alpha-1 antitrypsin molecules to bind to one another to polymerize. The polymerization within the liver cell prevents secretion, and so the Z-type protein accumulates within the liver cell and is not secreted in normal amounts into the bloodstream. This therefore produces a deficiency in the bloodstream, which decreases the lung's ability to protect itself against proteolytic burdens from inflammatory insults to the lung, like infection, like inflammation, like cigarette smoking. And the lung, therefore, with severe deficiency, is at risk of degradation of elastin and the resultant emphysema. And this is the pathophysiology of alpha-1 antitrypsin related emphysema. On the left, one sees a Z-type molecule with the single amino acid substitution of the lysine at position 342. You can see in the bottom of the left panel, there's an open space in the molecule, and that open space accommodates, as shown on the right, an adjacent molecule which intercalates one of its protein arms into that vacant or open space, which allows the two adjacent molecules to polymerize. And as one sees here, again graciously provided from David Lomas's laboratory, that here we see a series of polymers. That is to say, one yellow molecule of the Z-type is binding to a red molecule of the Z-type is binding to a blue molecule, and these polymers form within the liver cell, which then prevent secretion of the protein and cause an accumulation within the liver cell of abnormal inclusion bodies, which stain with a characteristic pattern, eosinophilic pattern, that are called PAS, periodic acid Schiff, diastase resistant, that is to say they are not glycogen, and on liver biopsies of individuals with the ZZ variant, which is shown here, one sees within the hepatocytes these abnormal PAS positive diastase resistant inclusion bodies, which on immunologic testing, on immunoperoxidase staining, are pure Z-type alpha-1 antitrypsin. So the liver biopsy, although only selectively done in patients for whom liver disease is a concern, this liver biopsy may be highly suggestive, although not pathognomonic of alpha-1. These inclusion bodies can be seen in other conditions, including during pregnancy, etc. Now, I mentioned this is a genetic disease, and it's inherited as an autosomal codominant condition. The alpha-1 gene is on the 14th chromosome, not on the sex chromosomes, hence it's being autosomal. It's named according to this nomenclature system of PI, standing for protease inhibitor, followed by the two allele names. In the case of the most severe deficient homozygous, two same alleles, ZZ type. In the case of the normal individual, PIMM. And in the case of the carrier or heterozygote, PIM, normal, and Z, abnormal. Again, there are over 120 alleles, and they're named according to their migration within an isoelectric field. Hence, the normal M type is in the middle. The Z type is the slowest migrating in an isoelectric field of pH 4 to 5. Now, the concept, finally, of a protective threshold value is very important to our diagnosing individuals. And the concept has emerged that one needs about 11 micromolar or about a serum level using nephelometry of 57 milligrams per deciliter in the blood in order to minimize the risk of excess emphysema in such individuals. That is to say, one may have serum levels below normal but still above the protective threshold, and in general, such individuals are deemed to be at lower risk of developing emphysema than those whose serum levels fall below 57. This is shown in the following analysis, in which various phenotypes are listed on the left column and the emphysema risk on the right, and the serum levels, both in micromolar and milligrams per deciliter, are in the middle. And as you can see, normal MM type individuals generally have serum levels in the normal range, 100 to 220 milligrams per deciliter, as we said. That individuals who are double heterozygotes, S and Z, have serum levels that straddle this 11 micromolar or 57 milligram per deciliter value. And those individuals, as a population, particularly if they smoke, are in fact at increased risk of developing emphysema. But the risk is yet even greater in individuals who you can see are ZZ, the PIZZ type. They have serum levels that all fall below 57 milligrams per deciliter and are deemed to be at increased risk, albeit not perhaps even as high as those individuals that are so-called null, who have no circulating alpha-1 antitrypsin as a result of a translation problem or nonsense mutation that prevents translation of alpha-1 antitrypsin protein completely. These individuals, although fortunately very uncommon, are at very high risk of developing emphysema. Again, one sees the correlation on the vertical axis between serum levels here in micromolar and the various phenotypes listed on the bottom, from normal on the left, MM, to ZZ on the right, with the red line showing that the protective threshold value of 11 micromolar or 57 milligrams per deciliter. You can see the ZZ individuals cluster all below that protective threshold value, whereas the SC individuals straddle that line. So, in concluding our first description and discussion of alpha-1 antitrypsin, I'd like to submit that this condition is common, but clearly under-recognized, and we've discussed the various lines of evidence that support that. That in addition to enhancing awareness and diagnostic testing by physicians, family practice doctors, general internists, pulmonologists, hepatologists, allergists, allied health colleagues, in particular respiratory therapists who are at the front line and are seeing patients, particularly with lung disease, may certainly enhance our diagnostic ability. That the mechanism of lung disease is different for the lung than the liver. In the case of the lung, it's because we do not have adequate protection against proteolytic damage from neutrophil elastase and other proteolytic enzymes. In the case of the liver disease, which we'll discuss in the next talk in greater detail, the liver disease presumably relates to the toxic so-called gain of function in which the protein accumulates in the liver cell abnormally. The concept of the protective threshold value of 57 milligrams per deciliter is very important and allows us at the bedside to render a diagnosis with relatively simple and inexpensive testing. So with that said, I'd like to conclude the first part of this conversation. We will continue the discussion in parts 2 and part 3. Thank you very much.